Okay, thank you very much, Elin, for the introduction. And obviously, great to see everyone here and obviously everyone on Zoom as well. So let me just start with my slides. So I'll be giving a talk about obviously updates in lung cancer. I did give a similar talk last year, so I have reused some of the slides. So I apologize if obviously people did attend the talk last year, that there will be some repetition. But I think it will be important and useful for people that didn't attend last year to just understand some of the basics as well. The main thing, I guess, is that hopefully this can be interactive. So scan the QR code, enter in any questions. An hour is a long time to listen to me talk. So I will try and introduce some breaks to try and answer any questions throughout as well. So I'll leave a little bit of time to allow people to head to either this website, enter the code, or scan the QR code. And please feel free to enter any questions and I'll try and address them along the way as well. Okay, so I might move on. So to start my talk, I show this image of this. This is actually a book. It's an autobiography, or it's a memoir written by this author, Paul Kalanithi. So the book is called When Breath Becomes Air. And when I was in my oncology training, this was actually a book that came out. It was a worldwide bestseller, as shown there. And it's actually a story about a patient with lung cancer. But the important thing is that he was actually a doctor. So he was actually a neurosurgeon. He was in his training for his neurosurgery fellowship. He started to develop symptoms. And during his training, he actually developed stage 4 lung cancer. And so this story is actually his own memoir, his autobiography about his journey with cancer. And I think it provides you pretty unique perspective in terms of obviously a patient going through lung cancer, but also being a doctor as well. And so understanding both sides of the doctor-patient relationship. Unfortunately, he wasn't able to finish his book, so his wife actually wrote the last chapter of his book. But I think it's something that was inspirational to me during my training, and I think it provides a unique perspective, as I said, and I think for patients as well, it provides hope, and it is quite a powerful novel. So I think it is something that even us as doctors, patients, we can draw inspiration from this book. So I just wanted to give also a little bit of brief background about myself. So I'm actually not Singaporean. I was actually born in Sydney, grew up in Sydney, did all my oncology training in Sydney, and did a lot of research as well in Sydney at the University of Sydney and the CSIRO, which is the Australian Government Research Organisation. But I came across here to NCCS maybe around 6-7 years ago now, and I have obviously been here since. And as Elin mentioned, I initially did a fellowship in both lung cancer research as well as phase 1 clinical trials. So I've tried to continue, obviously, a lot of these efforts in terms of clinical trials and research. And hopefully I can bring some of this experience and explanations in terms of what has been the latest updates in lung cancer in the past few years, as well as what we can look forward to in the future as well. So as a brief outline to my talk, I will be going through just a little bit of the basics about understanding lung cancer, obviously how we diagnose lung cancer, what are the different tools and technologies that we use currently as standard of care, as well as what may be used in the future. Obviously, importantly, go through some of the latest advances in treatment. And finally, looking at clinical trials, which we really see as a way to access the future treatments, tomorrow's treatments today. So I'll start with a little bit of the basics in terms of understanding lung cancer itself. So what is lung cancer? And at its basics, lung cancer is uncontrolled growth of abnormal cells in the lung. And traditionally, we've subtyped lung cancer based on the appearance under the microscope. So there are predominantly 2 types of lung cancer that we think of. One, non-small cell lung cancer, which obviously, as we can see here, represents a majority of lung cancer. And the other major subtype is small cell lung cancer, approximately 12.5%. And obviously, this is based on what it appears under the microscope. So small cell lung cancer, the cells have large nuclei, they're small cell appearance, and we categorize the rest as non-small cell lung cancer. But even within these different subtypes, there are further subtypes that we categorize lung cancer. Particularly for non-small cell lung cancer, we look at classification based on further subtypes based on the microscopic appearance. So we have adenocarcinoma, which represents the majority of non-small cell lung cancer, but also other subtypes such as squamous cell carcinoma, as well as large cell carcinoma. But of course, fundamentally, we also know about cancer that it's generally caused by mutations in the DNA. So it's a genetic mutations, genetic disease. And this is a picture of a Brazilian ophthalmologist who actually 150 years ago was the first to describe a family with hereditary retinoblastoma, so eye cancer. And here's a picture of Watson and Crick, who of course discovered the double helix structure and model of DNA. But importantly, this particularly applies to lung cancer because it has changed the way that we also classify lung cancer. And of course, here we have the pie charts that I've shown previously looking at non-small cell versus small cell lung cancer. We further subtype this into adenocarcinoma, squamous cell carcinoma. But now there's this emerging classification based on the genomic subtype. And I know obviously many patients will be aware of this based on their own cancer. So this is a pie chart here showing the different oncogenic drivers, we call it, or different genetic mutations or changes that we are now able to further subtype lung cancer. So this pie chart on the outside circle shows Asian populations. On the inner circle is Western populations or Caucasian populations, because there is also this genetic and geographic difference as well. But importantly, it's not just subtyping and classifying lung cancer. It's also important for treatment and understanding how the cancer develops and how we can treat the cancer. So we do need to understand the biology of the tumor to be able to understand how to best treat the cancer as well. And that has led to this concept of precision oncology, where we are now able to directly target cancer cells based on the genetic mutations with the right treatments. And so historically, treatments were given to all patients based on obviously the subtype of cancer being lung cancer. But we know that obviously with many treatments, not all patients will benefit. Some patients may respond, but some patients may not. So we want to give the right drug to the right patient, but we need to understand the tumor biology and understand the right target as well. So that's where this genetic classification has become really important, particularly for lung cancer, but also for many other cancers as well. And it's important because there are now targeted treatments for many of these different subtypes. So here we can see, and this is all within the past 5 to 10 years, where there are many different drugs that have become approved for the different molecular subtypes, and also many different drugs for patients that may potentially not have some of these oncogenic drivers as well. And I'll go through, obviously, a lot of these treatment advances in later slides as well. But really to emphasize this point, what we call targeted therapies, so treatments that target these specific gene mutations, have really changed the treatment landscape for non-small cell lung cancer in particular. So even as recently as prior to 2009, treatment was really limited to chemotherapy, and it was given just based on the histology for non-small cell lung cancer versus small cell lung cancer. But over the subsequent years, with the discovery of these genetic mutations which drive the cancer, obviously treatments to target these different mutations were developed and obviously have become approved and used in standard practice. And the following slide as well just shows really how over time the number of drugs that have been approved has really exploded. So particularly for some of the common or earlier oncogenic drivers or mutations where targeted therapies were approved, here we can see treatments for mutations such as EGFR mutations, for changes such as ALK rearrangements, initial treatments here. But over time, there have been multiple different drugs from multiple different drug companies that have been approved, which has really changed the treatment outcomes for patients. And here we can see just the number of drugs for the different oncogenic drivers as well. And this figure is only up until 2021. So even in the past few years, there have been further drugs which have been approved and become available. But I also wanted to emphasize that lung cancer in Asia is different to Western populations as well. In particular, for lung cancer, many patients may have a mutation in a gene called EGFR. And it is interesting that perhaps this mutation is really only found in lung cancer. It doesn't seem to be found in other types of cancer. But there is this stark difference in Asian versus Western populations. So in Asian populations of lung cancer, it does represent maybe up to half or even 60% of patients with lung cancer, compared to Caucasian populations where it may represent only 10 to 15% of patients. Unfortunately, we don't fully understand why this is the case. We don't understand why this necessarily develops in Asian populations versus Caucasian populations. But this is an ongoing area of research, and obviously this is important. And we do a lot of work here at NCC, specifically looking into this. But that is why research is important, and we're fortunate to be working in a center here at NCC that has a lot of research capabilities, invests a lot of resources into research. And particularly for Asia, there is this opportunity to develop research, particularly for subtypes of lung cancer, such as EGFR, that are really predominant and prevalent in Asian populations. So importantly, Asia obviously also represents a large proportion of the world's population. But historically, particularly for science and research, Asia has obviously been seen as a singularity, and the diversity within Asia perhaps has not been appreciated well enough. And there is this opportunity for research, and it is something that for patients as well, it's an opportunity for patients to advocate for research, to advocate for your own outcomes, for lung cancer patient outcomes within Asia, to really promote patient advocacy, in particular on the global stage as well. And perhaps even further to that, even within Southeast Asia, there is a lot of opportunity and a lot of importance to understand outcomes for patients with lung cancer, to develop further research and everything, not just within Asia, but within Southeast Asia as well. So I'll move on now to look into a little bit more detail in terms of how we diagnose and initially subtype lung cancer. So how is lung cancer first diagnosed? Well, obviously, when patients may potentially present first with symptoms, as doctors, we will do a history and examination, further characterizing the symptoms, examining to look for any potential signs. Obviously, then we do often basic investigations such as blood tests. Patients may undergo chest X-rays, but importantly, imaging studies to obviously evaluate the body. And typically this may be with CT scans, MRI scans, and PET scans are different options for imaging. The next important step is obviously, as we've seen, the different subtypes of lung cancer, is to obviously get a sample to be able to look under the microscope, to do further testing, to be able to subtype lung cancer. And obviously, firstly, this is to diagnose the lung cancer, but then subtype. And this can be done through various methods as well. Bronchoscopy is putting a camera down into the lungs to be able to get a sample that way. Transthoracic needle biopsy is putting a needle in from the outside through the skin to get a sample of the tumor. Or potentially, sometimes we may also do surgery, whether it be mediastinoscopy or thoracoscopy, putting a camera into the chest wall to be able to get a sample of the tumor that way as well. I'll go through a little bit more detail in terms of imaging studies. And importantly, this is to allow us to also stage lung cancer. And importantly, the treatment options will also differ depending on the stage of cancer as well. And so in general terms, we think about stage 1, 2, 3, and 4 of lung cancer. Stage 0 or pre-stage 1 lung cancer is perhaps when it is still confined into the airways and not having spread into the lung tissue or outside of the lung. Stage 1 to 3 where it is still confined to the lung or potentially some of the nearby lymph nodes. And stage 4 is when it may have spread to other parts, including the other lung, for example, or other parts of the lung, or other parts of the body, including other organs in the body as well. But move on now again to talk a little bit more about the different options in terms of biopsy to get a sample of the tumor. And just to re-emphasize the point that obviously this is our subclassification of lung cancer, where we look at the molecular subtypes as well. So typically we perform tissue biopsies where we get an actual sample of the tumor itself. And then to understand the different molecular subtypes, we perform what we call molecular profiling or genetic testing. And there are various different methods through which we can do that. The fine details are perhaps not so important, but we can do that through various scientific techniques such as PCR testing, IHC, and FISH. One particular method of testing that has become much more prevalent in recent years and has been standard here for a few years now is next generation sequencing. So this is something that in particular, we've been fortunate in Singapore to be able to do this routinely for lung cancer patients for the past 5 years or so. But in many parts of Asia, particularly Southeast Asia, there's still limited access to some of these testing techniques. So this is something, an area in particular that NCC and our research teams are looking into improving access to some of these testing techniques for other patients in Singapore, but also in the region as well. But here I show a picture of a woman holding a tiny blood tube, and I'm not sure if anyone can recognize who this is, but this is actually a woman called Elizabeth Holmes. She actually founded a company called Theranos, and this was about 10 years ago now, where it was actually what we call a healthcare tech unicorn. So she had a company that was worth $10 billion, purported to be able to perform a blood test using such a tiny amount of blood. Unfortunately, she was convicted for fraud, and again, here's a book, to describe her story. She was convicted a couple of years ago. It went through the court system and everything. But I show this because actually the technology for blood testing is actually something that we do also have available now. And it is something that we are starting to incorporate it commonly for patients with lung cancer. And of course, many patients here on Zoom may have had some of these types of tests done already as well. So this is something that we actually call liquid biopsy. So we can actually perform some of this molecular profiling using blood samples as well. So we know that tumors, of course, importantly, we can try and get a sample of the tumor itself by putting a needle into it. But the tumors also will potentially shed some of their DNA into the bloodstream as well. So we can then detect and collect some of these shedded mutations or shed DNA, and often they're fragments of DNA. We can collect these using a simple blood test and perform some of the testing this way as well. But liquid biopsy itself is actually a pretty broad term. So when we think about liquid biopsy, we commonly talk about looking for what we call circulating tumor DNA or ctDNA to look for mutations in the bloodstream. But there are obviously many different types of samples that we can collect from patients. And so potentially liquid biopsy can also refer to other types of fluid, for example, pleural fluid, which is fluid taken from outside the lung, potentially other types of fluid as well, to be able to perform these types of tests. A lot of these tests are still under the research setting, so they're not quite used as standard tests in our practice, but potentially in the future, these may be options as well. And just to put a little bit of a slide in terms of what we may potentially do in the future. So of course, at the moment, we test for what we know in terms of the common mutations that we potentially can find in patients. But in the future, we likely will be performing much broader, what we call sequencing or profiling of patients. So again, these are all things that we are already doing under the research setting, not quite for routine practice, because we don't quite have the evidence or the information that it is necessarily helpful. But we do a lot of it under research, and it may not be so far away in the future where we perform what we call things like whole genome sequencing. So we can actually profile the entire genome, 20,000 genes, and potentially this may help obviously patients in terms of selecting treatments, that may be more beneficial. But it's not just things like genome sequencing. It can also include things like RNA sequencing. Obviously, we know that cancers are very complex. There are many different components, including the immune system, that we can profile to potentially help patients as well. And of course, all of this is a lot of information, a lot of data, and potentially AI is something that may come into practice. There's a lot of obviously hype about things like AI. We don't routinely use it at the moment, but potentially in the future, these things may become much more commonplace. Okay, so I'll move on to talk a little bit more, obviously, about treatment options and particularly some of the latest advances in treatment. So again, I'm just going to start with a fairly basic background in terms of what different types of treatment there are. So in general, when we think about treatments for cancer, we think about local versus systemic treatments. So local treatments will obviously deal with local areas, so surgery to cut out certain parts of the body or obviously certain tumors within certain areas. Radiation treatment, obviously delivering radiation or X-rays to specific parts of the body that are targeted. But then, of course, we have systemic treatments, and systemic treatments are what we mostly deal with as medical oncologists. And these are drug treatments that try and go throughout the body to treat wherever in the body the cancer may be. So these are in broad categories, things like chemotherapy, but as mentioned in more recent years, targeted therapies that work slightly differently, that have different mechanisms of action to target specific gene mutations, and also in particular recent years, immunotherapy. So immunotherapy, again, another class of treatment that has really changed cancer treatment, where it tries to use the body's immune system to treat the cancer. But again, I'll go through in subsequent slides, but the different treatment options may be relevant for different stages of the cancer, different subtypes of lung cancer. So obviously, for different patients, the treatment options may vary as well. So again, another picture here. And again, I'm not sure whether anyone will be able to recognize what this is, but this is actually one of the first drawings of a white blood cell. So this was actually from 1877. And it was actually first described by two pathologists, one French pathologist, one British pathologist, who first described the white blood cell under the microscope in 1843. But importantly, these two pathologists also were the first to describe the normal structure of the lung. The French pathologist was the first to describe lymphangitis carcinomatosa, which is a type of cancer that spreads to the lung. So there is this long history of the immune system, white blood cells, and the lung as well. But again, that's where as I mentioned, immunotherapy is a particular class of treatment that has really revolutionized cancer treatment in general, to be able to use the body's own immune system to treat the cancer. And this is just the cover of Time magazine, the cover of Science magazine, where a few years ago, obviously a lot of hype around immunotherapy in terms of how it's changed cancer treatment. But in general, when we think about what we use commonly in the clinic in terms of obviously treatment for cancer, there are two main classes of immunotherapy, blocking certain proteins that cancer cells and immune cells express, called PD-1 and PD-L1. And importantly, I guess in simple terms, the general mechanism of immunotherapy for these agents is that cancer cells find a way to hide from the immune system in the body. And they do this by expressing various proteins on their cell surface to be able to hide themselves from the immune system, to prevent the immune system from actually eradicating or getting or killing off the cancer cell. But these treatments actually are there to try and unmask the tumor. So it tries to block the expression of these proteins to then allow the immune system to then recognize the cancer, to be able to treat and to kill off the cancer cell. So this is the treatment that has really changed the way we treat lung cancer, has changed the outcomes for many patients with lung cancer. And so we've been using it routinely for more than 5 years now. So I'll move on now to talk a little bit more detail about the different subtypes of lung cancer. And I'll start off with small cell lung cancer, which represents maybe around 15% of lung cancer overall. And for small cell lung cancer, the staging is a little bit different, where we consider what we call limited stage versus extensive stage. And for limited stage, it's where it is still confined largely to the lung and perhaps some of the lymph nodes. But the treatment options will include things like chemotherapy and radiation, often together or sequentially, and in perhaps selected cases, surgery. But for extensive stage, if it has spread to other parts of the body, typically we may have options of systemic treatment with chemotherapy plus immunotherapy. So again, this is one particular subtype of lung cancer where immunotherapy has really changed the treatment options. But again, in recent years, there's always ongoing change, always ongoing improvements in terms of the options that we have for treatment. So for limited stage, where historically for many decades, even the standard treatment was limited to chemotherapy and radiation treatment, there is recent evidence that we can also use immunotherapy after chemotherapy and radiation treatment to treat limited stage small cell lung cancer as well. And that's with a drug called durvalumab. And again, for extensive stage small cell lung cancer, if the cancer progresses after initial chemotherapy and immunotherapy, there are recent approvals for new drugs. There's a new chemotherapy drug called lurbinectedin. And even more recently, perhaps in the last couple of months, there was recent evidence that we can even combine this particular chemotherapy drug with immunotherapy in the initial treatment setting. But one particular new treatment that has really, again, changed the way we treat lung cancer is a drug called tarlatamab. And this is something we call a bispecific T-cell engager. And this is the type of immunotherapy treatment. And importantly, this is the type of immunotherapy treatment that works a little bit differently to the immunotherapy that we have been traditionally using. So I'll describe a little bit more about this particular drug. So tarlatamab, as mentioned, is something we call a bispecific T-cell engager. But importantly, this is immunotherapy, but it's also targeted as well. So we know small cell lung cancer also expresses various different things on the surface of the cancer cell. In particular, one protein called DLL3, which is just a protein that's expressed on these types of cancer. But tarlatamab is a drug that actually targets not only this particular protein, DLL3, but it also targets CD3, which is found on immune cells or T cells, which are a certain type of immune cell. And so the way this treatment actually tries to work is that it will bind the small cell lung cancer cell, but also bind to the T cell to be able to try and bring the immune cell directly to the tumor to be able to then treat the cancer as well. And so tarlatamab is actually one of the first what we call BiTEs or bispecific T-cell engagers that we use for solid cancers, solid tumors. But there are, again, a lot of research being done to look at novel treatments, new treatments, including different types of BiTEs for other subtypes of lung cancer and other types of cancer in general as well. So move on now to talk a little bit more about obviously non-small cell lung cancer, which is representing around 85% of lung cancer patients. And again, the treatment options will obviously vary depending on the stage of cancer. So for what we consider as early stage cancer, stage 1 to 3A, typically treatment options may include things like surgery, and this may be followed with radiation treatment, chemotherapy, and more recently, potentially targeted treatments in immunotherapy as well. For stage 3B, where there is some spread to some lymph nodes in the nearby region, typically the standard treatment may be concurrent or chemotherapy and radiation together. And again, in recent years, in the past 5 years or so, we are also using immunotherapy after chemotherapy and radiation treatment for stage 3B. And for stage 4, again, we look more towards drug treatments or systemic treatments. But again, many advances, more new drugs available, not only chemotherapies, immunotherapies, but many different targeted therapies as well that I will obviously go through in more detail. So again, just another picture here, this is actually an American comedian from the 1930s. And he once said, when the Okies left Oklahoma and moved to California, they raised the average intelligence level in both states. So who is this? This is actually a comedian named Will Rogers. And reason why I show him is that a couple of statisticians actually termed the Will Rogers phenomenon to describe cancer stage migration. So this is where in current day, or as time progresses, we start to pick up cancers at the earliest stage much more frequently. Patients may be getting scans for other reasons, and we detect the cancers earlier, potentially before it has spread. And so we're now picking up much more patients with early stage lung cancer. I am Australian, so there was a New Zealand Prime Minister who once said New Zealanders who emigrate to Australia raise the IQ of both countries as well. So it is something that has been used in common parlance as well. But this is a figure just to show that, and this is just some data from the US showing that cancer survival rates in general, including for lung cancer, are improving over time. And in part, this may be due to not only better treatments, but cancer stage migration. So we are picking up early stage lung cancers much more frequently. And so historically, around 25% of patients may have resectable disease, or they may have cancer that potentially may be amenable for surgeries to be able to cut out the cancer. Whereas maybe perhaps 75% of patients are what we consider as unresectable, so perhaps surgery may not be the most appropriate treatment. But particularly for early stage disease or resectable lung cancer, there is a lot of change in the treatment landscape for early stage disease. And if we go back to the original slide demonstrating that obviously surgery is an important treatment for early stage lung cancer, perhaps followed by different systemic treatments, that's where in terms of patients that perhaps don't have mutations or alterations in certain genes such as EGFR or ALK, we now are routinely using immunotherapy treatments. And there is recent evidence from the past 1 to 2 years or so where potentially we can even use some of these treatments before the surgery. And perhaps this may potentially improve outcomes as an option for patients to use immunotherapy as well as chemotherapy before the surgery, as well as after the surgery as well. And perhaps this may be for several reasons. This may be that if we are giving some treatment sooner, we're able to obviously treat the cancer sooner rather than potentially sometimes needing to wait for surgery. Perhaps if the cancer remains in the lung, if we're giving some of these treatments may be more effective, and it may then subsequently improve later outcomes as well. For patients that do have potentially these mutations in EGFR or ALK, there is now evidence that we can use some of these targeted treatments after surgery as well. And so this figure here will just demonstrate that there are numerous different drugs that have been approved in the past 5 years or so as what we call adjuvant therapies, so treatments after surgery. So this goes back to immunotherapies such as durvalumab in 2018, targeted therapies, a drug called osimertinib in 2020, and then other immunotherapies such as atezolizumab and pembrolizumab, and more recently in 2024, a drug called alectinib for patients that have mutations or changes in the ALK gene. But again, as mentioned, there are numerous what we call neoadjuvant or perioperative treatments. So we are now starting to use many of these treatments before surgery, as well as after surgery. But again, just to re-emphasize the importance of research, and these are all things that we are looking into actively here at NCC. So we know that patients that have surgery, that have adjuvant treatment, unfortunately, there will be some patients where the cancer can come back. So we do need to try and identify these patients better to be able to improve the treatment options for these patients, to try and improve the rates of potentially trying to cure the cancer as well. And again, that's where, importantly, new technologies such as liquid biopsy may become important in the future. So, for example, a term we call MRD, or minimal residual disease, and this is where we potentially can take a blood test after surgery to try and see whether or not there actually may still be any cancer left behind that potentially we cannot see on the scans. And potentially this may help us in terms of guiding whether some patients may need further additional treatment after the surgery, or potentially whether they don't need additional treatment after the surgery, to try and prevent the cancer from coming back in the future. But I would say that unfortunately at the moment for lung cancer, it's not quite ready for routine use. We don't quite have the evidence that we can use these types of tests. There are some specific characteristics of lung cancer that mean it can be quite difficult to develop these types of tests. Whereas perhaps for other cancers, some of these tests may be starting to use a bit more routinely already. So move on now to look at stage 3B lung cancer. And again, as previously mentioned, typical treatment for stage 3B may be a combination of chemotherapy and radiation together. But again, in recent years, in the past 12 months or so, there has been evidence for targeted therapy, particularly targeting the EGFR mutation after chemotherapy and radiation together. And move on now to stage 4 as well. So stage 4, where, as mentioned again, typically the standard treatments are going to be systemic treatments. So treatments such as chemotherapy, immunotherapy, and targeted therapies. But many new treatments that have been developed, particularly in the past few years. Many new targeted therapies in particular, new immunotherapy as well. But also combination treatments. So not just using these drugs on their own, using them combined, whether it be targeted therapies and chemotherapies, or even a combination of potentially all three different classes of treatment as well. So I'll try and do a little bit more of a deeper dive into some of these different molecular subtypes as well. So again, just flashing up this slide of the different molecular subtypes as well as the different approved treatments. And I'll start with obviously the common subtype of lung cancer, patients with EGFR mutations. And again, just a historical slide, just showing a couple of gentlemen here. And again, not expecting anyone to recognize these two people, but this is actually Kaplan and Meyer. So for us as oncologists, and working within science and research, the way that we evaluate treatments is typically done, obviously using clinical trials, but the way we report clinical trials is often done using what we call Kaplan-Meier curves. And this is an example of a Kaplan-Meier curve. I'm not going to explain it in too much detail, but essentially this looks at how patients do when they receive treatment, in terms of how effective the treatment is. And this is a particular historical example of one particular Kaplan-Meier curve that for anyone in oncology may instantly recognize. And this is actually one of the first study which proved a targeted treatment against EGFR in lung cancer. So this was a drug called gefitinib, which is what we consider a first-generation EGFR inhibitor. And this was the first study that was presented, and first the results came out in 2009 to demonstrate that we can use these targeted treatments for cancer. And interestingly, at the time, and this was presented by an oncologist from Hong Kong, he had actually written an editorial or a paper describing it as a small step towards personalized medicine for non-small cell lung cancer. But of course, we now know that it was not just a small step. This really paved the way for all of the targeted therapies that we actually have available. And if you remember, obviously, the previous slide demonstrating just the number of different drugs that have been approved for lung cancer. And obviously, there are many more for other types of cancer as well. It really has changed the way that we treat cancer. So what about EGFR in our current setting? So if we think about, obviously, when patients can have different lines of treatment, they can have first line and second line treatment. In the past, probably 4 to 5 years or so, the standard has predominantly been using a drug we consider a third generation inhibitor called osimertinib. And there was a clinical trial which demonstrated that osimertinib was effective for EGFR mutated lung cancer called FLAURA. And so typically, the standard treatment pathway for many patients may have been using a drug such as osimertinib as a first line therapy. If unfortunately the drug may no longer be effective, then moving on to different treatment options such as chemotherapy. But again, in recent years, particularly the past 1 to 2 years or so, this is changing with new evidence, with new treatment options and approaches. So in fact, for EGFR mutated lung cancer, there are in fact now many different treatment options. We still have obviously targeted therapies, what we call TKIs or tyrosine kinase inhibitors that are small molecule drugs. So these are drugs, tablets that can then target the EGFR mutation. And of course, we have chemotherapy. So chemotherapy is a standard treatment for cancer that has been used for many years. And there are many different types of chemotherapy that we can use for lung cancer as well. But there are actually many different other treatment options as well. There is evidence that we can use anti-angiogenic therapies. These are just a couple of drugs examples here. And these are treatments that target how tumors form blood vessels to be able to treat the cancer. We have some evidence for potentially using immunotherapy, perhaps not for every single patient with EGFR mutations, but perhaps for some selected patients, we can use immunotherapy as a class of treatment for EGFR mutated lung cancer. And again, more recently, other targeted therapies, including treatments that target a particular gene or particular protein called MET or MET. And even more recently, even within the past 1 to 2 weeks, there's actually been approvals for emerging therapies. And I'll describe this in a little bit more detail later, but something we call an antibody drug conjugate. So even in the past 2 weeks, there's been an approval for an antibody drug conjugate, one listed here, datopotamab deruxtecan for patients with EGFR mutations. So just demonstrating how quickly the treatment landscape can change. So importantly for EGFR mutated lung cancer, the recent evidence is really using potentially in some patients, and not every patient, but combination approaches in the first line setting. So where historically we've typically used these EGFR TKIs alone as what we call monotherapy or as single agent therapies, there's now evidence that we can combine them to potentially improve outcomes for some patients. And so we can combine these EGFR inhibitors with chemotherapy, and there's a trial that recently reported called FLAURA2. But we can also combine it with other novel treatments as well, one that we call amivantamab, and I'll describe this in a little bit more detail in the next slide. But this was evidence from a trial called MARIPOSA. So what is this drug, amivantamab? So again, this is a new type of targeted treatment. So this is a bispecific antibody. So this is an antibody treatment that targets 2 different genes, one EGFR, the other one MET. This is, again, one of the first types of bispecific antibody treatments that has been approved for cancer. And potentially this may have efficacy through various different mechanisms of action. It's not just about the antibody targeting the specific drug. Potentially it can also play a role with the immune system to eradicate or kill the cancer cell. But of course, as I mentioned, it's not necessarily for every patient. So there are many different factors that we consider when we think about what treatment options are available and what's obviously most appropriate. Obviously, not every drug is necessarily suitable for every patient. We need to think about the toxicities. Many of these treatments, new treatments, maybe IV treatments, which may not always be so convenient. Obviously, the drugs do sometimes take some time before they're approved and then potentially reimbursed as well. Obviously, there will be many factors important to patients that may determine whether they will be suitable for treatments in terms of being able to tolerate treatments, including other medical conditions, just the general fitness of patients as well. And of course, different factors related to the cancer and the disease. So whether the cancer may have spread to different parts of the body, in particular, we think about things like spread to the brain or brain metastases, even different mutation subtypes within EGFR mutations can influence whether different treatment options are appropriate. So we do need to often balance the pros and cons of different treatment approaches. And this is relevant for using combination approaches for EGFR mutations, but also any treatment really in general. So we think about obviously not only the efficacy of the treatment, whether it improves outcomes, whether patients will respond to different treatments, but we also think about obviously whether it leads to increased risks of side effects. And particularly for a lot of these new treatments where they're intravenous treatments, it can lead to obviously needing patients to be coming back to the center more frequently, coming for infusions, and it can obviously impact on quality of life as well. And particularly for a lot of these systemic treatments where we're trying to not only improve outcomes, but also maintain quality of life so that you can still live normal lives. Sometimes the intravenous treatments obviously can play a role and influence that as well. Okay, so I'll finish up there on EGFR mutations and move on to another subset, patients with ALK fusions or ALK rearrangements, changes in the ALK gene. And this is, again, another subtype of lung cancer where it has really paved the way for targeted therapies in lung cancer. And this is the only slide where I'll be showing more of these Kaplan-Meier curves. But this is an initial curve from patients with ALK rearrangements or ALK fusions in terms of their response to chemotherapy. And typically, chemotherapy historically may have only worked for around 7 months when chemotherapy was the standard treatment. And this is actually taken from the original trial of one of the targeted therapies called crizotinib. But recent outcomes from the most recent trial, and this is a new treatment called lorlatinib, what we consider as a third-generation agent. Patients typically may respond for even up to more than 5 years. And so this is really demonstrating how these targeted therapies really have changed the way that we treat cancer and really improve the outcomes. Where historically chemotherapy may have had relatively short and limited efficacy, but these new targeted treatments are really prolonging and improving outcomes for lung cancer. And lastly, I'll talk a little bit about another subtype, HER2 mutations, for which, again, new treatments have been approved. And so this is looking at another type of class of therapy called antibody-drug conjugates. And antibody-drug conjugates are essentially an antibody that target a certain protein or certain gene, but it's actually combined or linked to a chemotherapy drug. And so this is a way that we can potentially deliver the chemo directly to the tumor cell. The antibody-drug conjugate binds to the tumor directly to try and release the chemo directly to the tumor cell. And again, one of the fastest growing classes of oncology drugs that we have in development today. So particularly for patients with HER2 mutations, there's a drug called trastuzumab deruxtecan, which was approved in 2022. And again, as mentioned, in the past 1 to 2 weeks, another drug that was approved for patients with EGFR mutations. But as you can see here, many different drugs that are in development, many drugs in late phase trials that potentially may become approved soon. Okay, so one last section, and this is talking about clinical trials. So I think I've talked a lot about, the importance of research and how we develop drugs. So I'll probably skip over a few slides, but importantly, how do we actually develop drugs? How do these treatments get approved? How do we start using them in standard practice? And for cancer research in particular, obviously there can be any number of potential drugs that are developed. And typically there may be many thousands of compounds or drugs that potentially are developed and considered for potential research and treatment. But obviously there's a lot of research that goes into this in terms of testing these different compounds to see which one may be the most appropriate to then start test them in to start to test them in patients. And then we move them into clinical trials. So that's where we actually will test these drugs in patients. So obviously patients may enroll onto clinical trials, testing new treatments, and many of you, may be on potentially or have considered clinical trials in the past. But it is a long process, and potentially it costs a lot of money. Potentially even $1 billion or more for a single drug. To be able to test and prove that a new treatment is actually effective. And then even after a drug is approved, it will go through further testing, through further research to understand more about the side effect profile and to understand whether it's safe. So what are the different phases of clinical trials? Well, there are what we consider 3 phases, phase 1, 2, and 3. And phase 1 is typically where we are testing new drugs or new combinations of drugs in patients for the first time. So this is where the drug may have been tested in the lab or in animals, but we are now just starting to test them in patients. And typically these will be smaller trials, not so many patients in terms of total number. But the main aim of these trials may actually be to try and understand the safety profile, to understand what is the right dose that we should be using for this drug in patients. We are now starting to change the paradigm of how we do clinical trials, where even for early phase trials, where the main aim may be to understand the right dose and the side effect profile, we also want to enroll patients that obviously will potentially benefit from the treatment as well. But in terms of trying to prove that the treatment is effective, that's where it moves to phase 2 and phase 3 trials. And that's where we are testing the drug to see whether it's better than the current standard treatments. And so this is where phase 2 trials may be testing in a few hundred patients generally, but phase 3 trials may include many hundreds of patients, sometimes even up to 1,000 patients. And this is where potentially these trials can be randomized. So where one half of patients may receive the standard treatment that we use in routine practice, but the other half of treatment receive the new treatment, and that's how we compare whether the new treatment is effective against the standard treatment. And then phase 4 is where we are collecting information in terms of when the drug is already used as a standard treatment, just to fully understand the side effect profile and the efficacy as well. So I'll skip through this quickly, but what is the process if a patient or if you join a clinical trial? Often there's what we call pre-screening, where we have to check whether you would be potentially eligible for the trial. We then often have to perform additional tests to make sure whether you meet the exact eligibility criteria for the trial. Once you are keen to join the trial and potentially may be eligible, you sign the consent form. We start the process of screening, where we may formally do some of these investigations and tests before you then enroll on the trial itself and receive the actual treatment itself. Obviously, during the trial, there will be certain requirements in terms of the procedures that are needed to be done, in terms of whether it be obviously not just the administration of the treatment itself, but various blood tests, scans, and visits to see us in the clinic as well. Importantly, for clinical trials where we are testing a new treatment, the participation is voluntary. So it's important, if you are considering a clinical trial, if your oncologist has suggested a clinical trial, that you do read the information sheet in detail, you understand what the treatment is, and you are comfortable with the involvement on the trial and the procedures that are required. But it is voluntary, and importantly for trials, patients can withdraw at any time for any reason. So there's no obligation to join the trial or continue on the trial, and there will be no penalty if patients withdraw from the trial for any reason as well. But here at NCC, again, obviously we are fortunate to be a relatively large center, and we conduct a lot of clinical trials. We conduct a lot of phase 1 trials, early phase trials as well, trials of different classes of treatment, first-line trials, as well as later-line trials as well. And so again, for the different oncogenic subgroups, for the different molecular subtypes, we have different trials that may be potentially targeting different mutations. Even for patients that potentially don't have any of these mutations, we have many different trials that may be targeting either new targets or potentially for other classes of treatment, such as immunotherapy, and also for other stages, as well as, for small cell lung cancer as well. So all of these trials are generally listed on the NCCS website, so you can go through the website to look at what trials may be available. And obviously, importantly, you can discuss with your oncologist if there may be potentially trials suitable for you as well. Last few slides, just to mention a little bit about lung cancer screening. So this is obviously an important topic for lung cancer in general. And it is something that there are general recommendations about screening for lung cancer. It can be considered as almost a standard option, typically for people that have a history of heavy smoking in the past. But there is, and typically this is done using a CT scan. So if people are within a certain age, have a certain history of smoking, they can get regular CT scans done to be able to screen to try and pick up cancers early. And this is just the criteria here, and it is something that is available. It is reimbursed, so the costs will be covered. But again, I've mentioned that for many patients with lung cancer, there isn't that history of smoking. And so there are studies that have looked at trying to whether or not screening is appropriate and whether it's suitable for patients that or for people that don't have a history of smoking. And similarly, we're conducting a study here, it's termed SOLSTICE, to try and generate evidence to see whether or not screening for lung cancer for people with minimal or without a history of smoking, may be suitable. And for this study, it's particularly for people that have a family history of lung cancer. So if patients, their relatives want to look into this study, consent to this study, we can potentially perform screening, because there is perhaps some suggestion that there may be some link in terms of family history, although obviously it's not that everyone with a family history of lung cancer will develop lung cancer. But in this study, we're performing, again, CT scans. There will be some additional procedures such as blood tests and questionnaires. There's a QR code there if anyone is interested to consider, lung cancer screening, can go through the QR code here. So I'll finish there. But I guess one last point I wanted to sort of emphasize is that, giving a talk as a medical oncologist about treatments, how we diagnose cancer. But the important thing is that for patients, it's really the multidisciplinary team that's involved in patient care. So again, just to show this slide to indicate that it's not just the doctor and the patient, it's the whole team that's involved in caring for patients with cancer. It's the other specialties, it's the nurses, it's the allied health, and of course we've got the LEAP team, the patient navigators, that are obviously crucial in terms of how patients go through that journey with cancer. And at NCC, again, we try and incorporate this as much as possible. We do have something called a lung multidisciplinary clinic, where we can, as different specialties, see patients all together. So medical oncologist, radiation oncologist, surgeon, seeing patients all within the same clinic to better discuss the treatment options with patients, obviously if these different options may be potentially suitable. But again, it's not just about the doctors, it's about the allied health teams, it's about the patient support staff that are involved in caring for patients with cancer. And an important thing would be patient advocacy as well. So having patients advocate for their own treatment is really important to be able to institute change. And when we think about a lot of new treatments being developed, a lot of difficulty around getting these treatments approved in a timely fashion, getting these treatments reimbursed so that the government will cover the cost of these new treatments, which can be obviously quite expensive. And that's where it's important for patients to be able to advocate for a lot of these new treatments to be available, within Singapore, within our center. And I just wanted to maybe end on that note to emphasize that, it's not just about going through your treatment. You can also advocate for your own treatment and potentially your future treatment as well.